Hello, everyone. Welcome to the Imaging Wire Show. My name is Jake Fishman. We have an excellent episode for you all today. Star-studded cast. We have Elad Walach from Aidoc and Dr. Edward Steiner from WellSpan Health. They both have a really unique perspective on radiology and AI within radiology, and we're going to learn a lot today. And I can't wait to do that. So without further ado, Elad, Dr. Steiner, welcome to the show.
Thank you, Jake. Nice to be here.
It's good
Thanks for having us.
Good to have you. Just to get us started off for the folks who might not know you or want to get you know you even better, just give us a quick introduction to who you are and what you do within your organizations.
Great. I'll start. My name is Ed Steiner. I have been chair of imaging at WellSpan York Hospital in South Central Pennsylvania for 5 years. I currently just transitioned to become the medical director of our Advanced Prostate Care Center, but I'm still integrally involved with rolling out high-tech, rolling out CT, MRI projects. Just to give you a background, our system is large. It's 7 hospitals occupying central Pennsylvania, South Central Pennsylvania, literally all the way from Lancaster to heading towards Pittsburgh. We do 580,000 studies at York, so we're a large shop. In the system, we do approximately 1.4 million studies. And kind of this spans from rural to relatively more complex cosmopolitan hospitals and level 1 trauma centers.
And I'm Elad, CEO and co-founder of Aidoc. Originally came in from the AI side of things, headed an AI department, the Israel Ministry of Defense, and then fell in love in healthcare, and here for 5 and something years. Great,
welcome and awesome. I've been paying attention to what both of you have been doing. It's been really cool to see. So it's great to have you on. And one of the things that did make it into previous ImageWire issues was your partnership together and how you're working together to roll AI out across WellSpan, which I think is super cool. And Dr. Steiner, I wanted to kind of set the stage for that and learn a little bit about what you and what WellSpan were doing with AI kind of leading up to now.
Sure. Our drive for AI really started about 4 years ago. We implemented an AI program for stroke imaging, which became really successful. It was rapid, one of the first AI stroke programs. That got some traction. And at the same time, we were really redefining WellSpan in York Hospital. We purchased 3 brand new MRs, upgraded our other MR systems. We purchased 6 spectral CT scanners. And what I felt was, well, that's hardware. What are we doing for peopleware? What are we doing to help with image interpretation, which is a little more difficult. Hardware you could purchase. And I started pushing, with help from IT and from my partners, our initiative for improving turnaround time and improving detection, becoming better radiologists. And radiology hit a wall, really. And what I use when I talk to the board of directors is the miss rate in imaging is approximately 4 to 6%, no matter what you do. And our volumes have increased tenfold from the perspective of not only work, but images per modality. And I did some rough math, and when the board of directors or our administrators listened to that math, I just gave them some global numbers like, well, something, 40 million studies are misread in the United States per year using global numbers. If we read 1.4 million studies, and if you do that math, 4% of that is a large number, and that's not out of line with average. The miss rates are 4 to 6%. So then comes how do you do it better? and I was always interested in AI. We had some traction, and about 3 years ago at RSNA, I started really looking deeper into AI. And at around that time, I met Elad in one of his dinners, and I met his staff, and we spent some time together. And I thought that Aidoc had a good concept. And it took us 3 years to implement because we were very careful about it. And it's a large system. And so that's how WellSpan started. And frankly, it was just, we had a committee called the ITAS Committee, the Imaging Technology Assessment Committee, and I chaired that. And we really delved deeply into it. And I truly feel that our path was a correct path.
Thank you. I'm curious about maybe your story after that dinner and kind of what led up to at least this moment up until you started implementing a couple months back.
Yeah, I think that what we find is that a lot of it I would say that the ecosystem varies, right? And you have some health systems, that are, just want to get one solution or another. And some I think are more thoughtful, as Dr. Steiner led the process, where it's not just about one AI product or another. It's much more about developing a strategy and an approach, and being very thoughtful about it. And I think a lot of our conversations, it was evident that it was imperative for them to be very thoughtful about a lot of the considerations of how to really develop an AI strategy. How do you scale that after? What are the workflow considerations? I'm sure Dr. Stein would talk much more about this, but we felt it as well, that we have a really thoughtful partner on our hand. And this is why working with them, hopefully Dr. Steiner felt that we helped them think through some of these considerations, what we see and how we think about how having a unified AI platform can help solve some of those challenges when thinking about the future. So that was a bit of we're really impressed by how, again, I'll use the word thoughtful the process was, and for driving meaningful innovation that is good for the immediate term, but also has the long-term vision in mind of how this scales and develops over time.
When you look at the implementation so far, what does it consist of, and how is it going to be rolling out?
Well, if we go back again, I think one of the concepts that was near and dear to my heart is using Steve Jobs as a model for it has to be simple. It has to have minimal moving parts. If you look at a lot of our engineering solutions in PACS and in imaging, they're clearly superb, but they were designed by engineers where clutter is there in front of us. And rather than using a simplistic approach where depth and background information is handled without the radiologist knowing, the thing that attracted me about Aidoc is I wanted it to be transparent to radiologists. We've got too much to look at. We've got too much volume. So when we designed this, the important part of rollout for us is to have it completely integrated into our information system. We use Epic. I didn't want too much noise. What do I want? And one of our jokes is that one of my partners, he's the chair of one of our other hospitals, he loves Aidoc because he calls it Hey Doc, because it's as if there's a little voice that says, hey doc, there's an abnormality. Well, that's perfect. We're doing our work. The way we integrated it is by having the widget that Aidoc supplies, but not only the widget at the left lower corner of my screen that goes ding, and I could be doing anything. I could be doing administrative work. The widget activates when there's an abnormality. And all I have to do is push it, and it gives me a list of all of the abnormalities within the last anywhere. It's programmable. So we have 12 hours, okay? Non-intrusive. If I were reading a case on a stat desk, for instance, not only does that widget show up, but we've got Epic geared so that if an abnormality occurs, it takes that patient and moves it to the top of our list. It doesn't matter what we're doing. Mrs. Smith, who has an incidental PE in our office practice, ends up in bright orange letters at the top of the list. Again, what does it do? It tells us, well, that's a stat case. Aidoc has detected it. And we also rolled out modules very selectively. We started off with cervical spine fracture. We started off with the pain points. Cervical spine fracture, you don't want to delay reading on that. Intracranial hemorrhage, you don't want to delay reading on that. And PE. So those are, and PE was broken down into incidental, which is critical because those won't be read for 24 hours, 48 hours sometimes, or acute PE in the ED setting where rule out PE is your diagnosis. So you know that that's going to be read rapidly. So in rolling out, simplicity was key. And we can get into turnaround time and accuracy and interpretation ability and, you know, how accurate is this thing? Does it ding all the time? Well, then you get noise. Then you know, it just becomes background noise and annoyance. So we're currently doing a good primary study on not only turnaround time, but efficiency of Aidoc in these modalities. And it's there. It really is there. Out of the box. We always need to tweak things. To me, Aidoc's going to be a work in evolution. It's not in its final stage because the algorithms are going to change, because the way we're going to look at fractures is going to change. So right now it's doing tremendously as a first stage. I'm sure that we're going to be getting Aidoc tweaks continually. If we're not, then you know, they're not doing their job because perfection doesn't exist in our field. So that was our rollout and addressing our pain points, most important. And I'll tell you, I'll give you a vignette because I think IT folks are skeptical always. That's the nature of their beast. So I was on an IT meeting and we were just rolling Aidoc out. And I've got that little widget. So I wasn't reading cases, but I've got the widget. And the widget went ding, and we're talking about something else. And I looked down, and Aidoc found an interhemispheric subdural hematoma that was tiny. And I looked at it and I said, "Oh, you know, is it real?" So I just opened the case and I said, "Yeah, wow, it's real." And then I looked at the interpretation, the preliminary read. And the preliminary read was negative. So I immediately called my partner and I said, take a look at that. We didn't even really activate Aidoc officially. This was on our first week, just rolled it out that day. And my partner looked at it and said, "Boy, I think it's there." So that's it. That was wonderful. That was wonderful because it told us that, well, it could have been calcification in the interhemispheric fissure. It could have been. But regardless of what it was, Aidoc got us to look at it again. I then sent it was so subtle, I sent it to my neuroradiologist, Rita, who was on that day too. And she said, "No, I think it's blood." And so what did we do? We prioritized it. We followed it the next day. It was actually stable. But you know, that was like the second case I read from Aidoc, and it told the story, I think.
That's amazing. Elad, are you gonna try to adopt Aidoc as part of your one of your marketing campaigns? Or
I think I must. It's first of all, obviously I'm a big Bugs Bunny fan, so but this is actually yeah, I love it. Look, we've built the system. I remember it in the early days. We spoke with a radiologist. It was a neuroradiologist, and again, we asked him like, "Okay, radiology workflow, what do you need to do?" And he told us, "Oh, you have to minimize the number of clicks." And we told him, "Oh, great, so we'll do it like a one-click system." He said, "Guys, you're not listening. 0 clicks. When I say minimal, I mean 0 clicks." So that's kind of how we wanted this to be. And I honestly, I love the fact that they, you know, it is, you know, it is not disruptive. I think that's so important because radiologists are so bombarded these days. You know, we always hear about the radiology shortage, which I'm sure that the audience here hears even more these days, right? It's just staggering. And I think for any solution to be successfully adopted, specifically AI, it has to have the workflow considerations really top of mind. I will also add that the Epic integration was epic indeed. It was incredibly challenging to get the first few. And Dr. Steiner has been helpful with WellSpan to be really one of those first integration. But once it's happening, I think once the impact and the ability to really provide a seamless workflow is significantly better.
That makes sense. And Dr. Steiner, the thing you were talking about earlier about, I guess, the size and diversity of your system, that, was it processing 1.4 million scans a year or something like that, but then also have these hospitals that some are rural and some are urban, some are large. How does AI kind of work across a system that's that diverse? And then also, how does AI help in that type of setup?
That's a great question, and that was the challenge that actually helped us push Aidoc to administration. Right now, we have Aidoc rolled out at York Hospital and our satellite offices, and that's the 580,000 hospital case. And we just this week rolled it out to Ephrata Hospital and Good Samaritan Hospital. So we're ranging, our hospital system goes from 75 beds to 650 beds. And that's important because I'm not sure that everybody realizes that when you staff a radiology department, you don't have the ability to staff subspecialty coverage. My hospital has 32 radiologists. We are all academically trained, and it's a university type center. We're not academic, but we have probably about 10 academic programs in the hospital that we have to cater to. We have pediatrics, we have neurosurgery, neurointerventional. So it is easy for me to kind of go to the expert and to triage a little more. When we read stat studies, I mean, you're sitting at that desk, but for the most part, the neuro docs read the neuro cases, the abdominal docs, the abdominal cases. If you're at a smaller hospital, you're staffed by 3 radiologists. And one of them is doing mammography, the other one's doing barium work, the other one's covering the ED until the barium stuff's done, and the radiologists are all of our radiologists are board certified, but they may not be subspecialty trained in those fields. So take intracranial bleeds. As I said, a subtle bleed is dangerous. It could be deadly. And may not be picked up by somebody who's an abdominal expert, just as a neuro radiologist may not pick up that subtle free air. Okay, that C-spine fracture. Rib fractures I'm going to talk about only because they're embarrassing. They probably have very little significance, except when you're called by the patient and you say, oops, I missed a rib fracture. And it's hard to tell them that, well, it doesn't matter, because it does matter to them. It explains their pain. But in terms of acuity, again, rib fractures are the module we rolled out because it could be a harbinger of other issues. But, the concept that we have to have in imaging is basically a single standard of care. That's what the world demands. That's what everybody demands. In other words, if you show up in the Gettysburg Emergency Department or at York Hospital's emergency department, you should have the exact same standard of care. And that is difficult to do, and Aidoc helps. We need tools. We need to be able to provide that same service. So a doc sitting in Gettysburg who may not be an expert in neuroimaging, with the help of artificial intelligence and evolving artificial intelligence as we get better, can make the same interpretation, or at least say there is something wrong. I think Aidoc is as valuable at that. You don't have to get it right, okay? Yeah, you have to have enough sensitivity and specificity for it to work easily, but I like Aidoc because it says, take another look at this, because I think there's something wrong. And for the most part, I would say high 80s, probably low 90s, 90 percentile, it is there. If it overcalls, for instance, in a cervical, degenerative changes in a cervical spine look like fractures. They do. Old fractures look like fractures. They just happen to be old. But it gives us the opportunity to look twice. And if you're going to use that single standard of care, if you look at the number of misses out there, and if misses are 4 to 6%, a tool such as Aidoc is going to help minimize those misses. Now, interestingly enough, just to be true to everybody, including ourselves, that 4 to 6% is the same miss rate in academia as it is in private practice. It's very interesting that's it's almost a fixed miss rate, and a lot has to do with rate of reading, how rapidly, turnaround time, and again, we could get into that and how Aidoc could potentially help, and I think it does. But your turnaround time is critical, and your stress time is critical. And if you don't get to those emergency cases rapidly, you read faster. And if you read faster, your error rate clearly is going to go up. So it's a package. And from what we've seen so far, I think AI fits very well into that package in minimizing your miss rate, minimizing the turnaround time, detection errors. It's critical.
The setting that you described, where you have these highly trained radiologists, but are sometimes reading cases that don't line up with their subspecialization, or that 4 to 6% error rate that's just pervasive across all settings. There's groups in departments out there that you could say this about their group or department, but they're not at nearly as advanced into AI as you are right now. And what I'm curious about is, what do you think is holding those groups back? Understanding that, the reasons that you just laid out are, the same reasons that they, have right now.
I probably, several important factors are: number one, an overtaxed IT department, and perhaps, I wouldn't say lack of interest, but lack of initiative for change from a radiologist who's a champion. You really need somebody that is interested in change, interested in pushing it forward, in a setting where every IT department I've ever worked with doesn't have time. And when you tell them, well, we're going to roll out AI, and by the way, you've got just a light lift, and that's reprogramming Epic so that the AI actually notifies things. And by the way, we're rolling out spectral CT with 2 other significant applications that involve this. It's a matter of prioritization. And I think what happened in WellSpan is we had a great IT department that actually took this as a challenge. I mean, they actually lecture in the Epic realm because we've done so much customization that it's worked out great. Number one. Number two, we've got 3 docs, including myself, on this committee that were interested in it and saw the value. If you don't see the value, you're not going to push it forth. And frankly, how can you not see the value? So that was my question. Okay, I'm going to give you something that'll minimize your errors, maximize your workflow, and decrease your turnaround time. Is there any value to that? And number 3, you need to prove the value. And that's what was kind of thrown at us, where, well, you think Aidoc is going to work, pitch it. Let's have a pilot. Let's investigate. Let's prove proof of concept. And we're doing that right now. And our next questions are going to be, which modules are we going to go forth with? Right now we're looking at 5. And each one of the decision was that there's going to be a proof of concept for each module, because that's probably the right way to go. And the question that I can never answer is, well, is artificial intelligence in South Central Pennsylvania going to be as effective as in New York City? Where did the machine learn? What data was put into that learning machine to come up with the final algorithm? And Elad, you could help me with that one. But is it going to be the same? Is a machine trained in Europe with European radiology and European imaging going to work the same as a machine that uses the Mass General database, the Yale database in training it? And those are questions that I think are valid. I don't particularly know the answer yet.
Yeah, and if I can comment on it, I think those are really good questions. I will say that AI is morphing, and I love the concepts, of being validating and thorough. On the flip side, I think that, again, thinking about really scalability of AI. So even today, right, we already have, we talked about 5, we already have 9, right, since we started, right? And if we think about 3 years from now, I think we're going to be talking about dozens. And I think that another approach, it's not today or tomorrow, but I think another approach should take place where it's much more about the post-market surveillance, AI operations like dashboards, to get like a broader sense, because going like algo one at a time, it's just going to be honestly too slow. Like if we're talking about adopting dozens of AI solutions in the next 3 years, you can't do an accurate, you can always like test and see how it works. You just make sure it's valid. I'm not saying you should do that, but I think for scalability, I think we'll develop joint approaches together, right? I think that's going to be the interesting way. Can we do, how do we do that in a way that creates trust and transparency, does validate, so we're not just relying on, hey, it's going to work. How do we make the continuous measurement something that is more ingrained into day-to-day? So those are some of my thoughts on this specific challenge. But if I can comment on something else that Dr. Steiner said, I think that what he did very well, in my opinion, is looking at the broader enterprise picture. And I think that's actually essential for radiology, to not just look at, why is this good for radiology, but actually why it's good for the whole enterprise, right? A lot of the value, like why do you invest in better radiology quality? One could argue it's not for the radiology sake, it's actually for downstream of radiology, because you're impacting the ED throughput, and you're impacting the length of stay, and you're impacting, litigation if we're talking about misses. So I think that part of showing the value is connecting the dots across the enterprise, and which is something I think radiologists are very well positioned for, is how to look at the broader picture for the health system as an enterprise, and how does relieving this bottleneck, or improving or augmenting the imaging workflow, you can have an impact downstream. Dr. Steiner, curious to hear your thoughts on that.
Absolutely. Of course, as a radiologist, I believe that the world revolves around radiology. But in reality, the world revolves around patient care and efficiencies and communication. Getting to communication. I mean, no matter how accurate we are, if we can't communicate our findings in a timely manner with the emergency department, with private practitioners, with other hospitals, if we can't communicate between ourselves, then it's all for naught. You haven't accomplished anything. So I do look at it that way. I try to look at the panoramic. And again, just simplicity. If it's not simple, it's not going to work. And I like the simplicity of, it's abnormal, take another look at it, get that turnaround time down. Again, just to give you an idea, we read our private office scans 24 to 48 hours later. They're not acute. Our ED scans we read within 30 minutes. And most places do it that way. My old practice, same thing. You show up in the morning and you're 300-400 CTs behind, and by midday you've caught up, because that's the workflow. So that's tremendous. The liability associated with that is tremendous. Again, Mrs. Smith that shows up, that's got colon cancer, shows up in your private office. okay, and has a scan at 5 o'clock in the afternoon and has a large PE. And this is a common occurrence. So what happens is that, you come in the next day, and by the time you get to Mrs. Smith, it's 4 or 5 o'clock in the afternoon, and you go, whoa, there is a PE there. A common occurrence. This is every practice I know of works this way. And then you try to contact Mrs. Smith's doctor, and you can't reach them because it's 5 o'clock and they've gone home. And then you go into Epic and you say, let me call Mrs. Smith at home, because you've got to get her to an emergency department. And you hope she answers the phone. And then at the end of this process, you get a call from the referring physician saying, oh my, why didn't you pick this up earlier? And that's what we're trying to break. That is not good healthcare, even though we're intending to do this as efficiently as possible, and even though nobody does it any different. So how do we interject a product like Aidoc that basically rings that bell and says, there's a PE in your office? And we've done this study actually. And, and Aidoc actually has this as part of their presentation, and it's entirely accurate. Instead of Mrs. Smith's CT being read 48 hours later, that CT is read 20 minutes later. And that's good healthcare. That really is.
That is good healthcare. Elad, a couple minutes ago, you mentioned that, maybe 3 years out, there'll be dozens of AI tools.
Yeah.
And I guess one small question, then maybe one big question. So one small question is, how does one kind of select where to focus those tools, understanding that there's, I don't know, maybe 1,600 radiology indications, and maybe I just made that number up, but anyway. And then also for both of you, what is the future of AI and radiology, and how they continue to evolve together once we get past these, finding Mrs. Olson's PE and in notifying her earlier? Like, where does it go even further beyond that?
So in terms of your small question of how do we pick, you mean how do we pick what to develop? Is that the question?
Yeah.
It is. I will say it's a complicated process, because you never know until you really dig in what's the potential value of a solution. I will say the incidental pulmonary embolism, like we didn't know if it's even merits prioritization. Some people argued all of these are subsegmental, it's interesting but not as meaningful. Only after doing research we found that, obviously depends on the setting, but typically most of them are actually lobar and segmental. About 70% are lobar and segmental. So I think that data I think is important. So I'm saying all of that just to say that it's actually difficult to oftentimes know in advance, and the rigor behind choosing the use cases is incredibly difficult. The advantage, I think, so the process is this: you want to identify the things that give as much real value. Radiologists are typically aware of like the areas and disease states that they think one could have an impact, and then there's a lot of rigor in the data analysis, in the behind the scenes, like understanding, okay, what is the exact value proposition here? Is that measurement, or is it tracking the patients and coordinating care? Is that is that prioritization? Like what exactly are we trying to solve? And then building a solution that does all of that. So I think essentially the process is getting physician input, doing data research, and then building a lot of it. I think that's kind of how we're thinking about it. In terms of the future of AI question, I think keen to get Dr. Steiner's perspective. I will say that I think AI is becoming more and more of an enterprise infrastructure. So like we had in the PACS days, right? That PACS becoming an enterprise imaging, right? I think we'll see something like that with AI, where the insights from imaging are actually going to drive cross-specialty workflows. Dr. Steiner gave the great example of stroke, which I think really evolved in that end, like where you have stroke insights that help connect the teams. Where I think the key is connecting the teams and making sure all the different teams, radiology, neuroendovascular, neurology, are all connected. But I think that is an area where AI is going to evolve, really that care continuity, AI-driven care delivery, where it's really across the care continuum, multi-service line, multimodal approach to AI, where it's really going to be, I think we're going to have a layer that is like, okay, you have your EHR, you have your PACS, and you have your AI layer on top of everything that helps drives patients across the care continuum. It's very broadly, but that's kind of how I think it will evolve.
What do you think, Dr. Steiner?
I'm gonna divide the problem into acute care, things that enlarge and go pop, such as aneurysms,
Yeah.
Such as large vessel occlusion, myocardial infarction. PE is a great example. Such as hip fractures, because in little old ladies and little old men, hip fractures end up being terminal events, because the difference between total hip replacement and pinning is critical. So I think AI clearly has near-term roles in all of these, and has already tackled many of these problems, and we'll see where it goes. So those are quite obvious. Free air, for instance, that means there's trouble, and we're all very, very comfortable with that. Chronic care and population health, those are kind of the silent places that AI should help. Coronary artery calcification linked with stenosis. More chronic aneurysmal dilatation of the abdominal aorta that's not going to blow now, but you're going to follow it. Osteoporosis, which could be discerned from conventional scanning, and AI, I would anticipate, will be able to help us with algorithms that give us readings. So chronic care, situations that may not be apparent, but we scan routinely, where AI can just flag this as a potential abnormality. And the third thing that I see is the ability to get your day's work done and get your patients done in an intelligent manner. So, and AI has been used for this by Amazon and by, it's like, where do you open up your Dunkin' Donuts shop in New York City? Well, there's pretty good data about that. And if you do it intelligently, AI is going to help discern the patterns. When patients come into my hospital, okay, I don't want a patient sitting more than 10 minutes without being seen. I want the registration process to be there. When I do an interventional case in a large hospital, I want the nurses, I want the ultrasound equipment, I want the angio suite, I want my technologists, and I want my physicians to be in that place at the same time, rather than haphazardly scheduling. Scheduling is a very, very difficult process in these systems that are not necessarily linked well. So I see AI as, and again, I've looked at University of Maryland designed a beautiful program that basically does that is like the policeman or the integrator. We do, for instance, we do 65 interventional cases a day, okay, in my hospital and private practice, which is 10 minutes from the hospital. And you know something? We probably could improve efficiencies by using an AI program, and we're looking at that. So that's, the global AI world, I think, is pretty wide open. Not only in imaging, but in almost everything we do. And we're currently, I think, touched by AI in ways we don't even know about, whether it's hard-coded, whether it's, I do a lot of men's health. So prostate is something that, prostate MRI is very difficult to read. It just is. And it's being read by folks that have a lot of experience and folks that have very little experience. And it's cancer that can potentially kill a patient. So, and I think AI has a tremendous role, and we're looking at some AI programs that really have really made some strides in again, single standard of care. I read 900 prostate MRs a year. Okay, I want somebody who reads 20 a year to get it right. It's not my ego. I want everybody to be well served. I want great readers. I don't want to be the reader that people necessarily go to. I want everybody to be a reader that people go to.
Thank you. This has been amazing, guys. The Dr. Steiner, what you said about essentially just how much we might just be at the tip of the iceberg, but the impact that it could have is really exciting. And as part of that, then the impact that radiology can have. And that's just as exciting. And I want to thank you both for coming. I want to commend you both for all that you've achieved. Dr. Steiner, in terms of pushing your system forward on the technology side, and Elad in terms of pushing the world of radiology AI forward, and all the folks on that Aidoc team. It's really special. So kudos with you. Thank you for coming in. And for everybody who's watching out there, thanks for joining us.
Great. Thank you very much for the invite.
Thank you.